Hi, this is Junaid, again with Acute Ischemic Stroke 2019 Guideline Review. In this section, we're going to review IVtPA complications and its reversal. The most horrific complication that we are worried about is symptomatic intracerebral hemorrhage. How do you define symptomatic? The word is symptomatic intracerebral hemorrhage. So let's first define how it is defined on the radiographic appearance of intracerebral hemorrhage. And these are three different ways that, as you can see, that we have defined intracerebral hemorrhage: the NINDS, and then of course the Heidenberg classification. To be honest with you, the most widely used is, at the end of the day, is the ECAS one. NINDS is very simpler. It says that if there is punctate infarct, it's called H1. If it's PH, is basically typical homogeneous intracerebral hemorrhage, the ball of bleed in the brain that you can see, and that's the radiological appearance of the bleed in the brain. As far as the ECAS is concerned, that is more delineated into H1, H2, PH1, PH2. H1 is small petechial hemorrhages, which is, to be honest with you, expected in some of these cases. More confluent plaques, if you look at it, that's considered HI2. And then PH1 is less than 30% of the infarcted core with mild space occupying lesion, and PH2 would be more than 30% with significant space occupying lesion. And that's how ECAS derived it. However, the Heidenberg classification goes into more detail. It takes one step forward and also classifies 3A, 3B, C, and D. And 3A is actually parenchymal hematoma remote from the infarcted area, and that has happened. You actually go ahead and give TPA with right-sided symptoms representing the left side of the brain, and you do a CAT scan in 24 hours, and you see a small bleed on the other side of the brain. So that is not unusual to see. Sometimes you see them, and those are the areas that you actually have to consider. Again, these are radiological. We're going to come to the word symptomatic intracerebral hemorrhage. The word symptomatic is the key here. And then, of course, interventricular hemorrhage, subarachnoid hemorrhage, and subdural hemorrhages can happen in these cases, and you can classify them accordingly as well. Now, as far as the symptomatic classification is concerned, as you can see, different clinical trials have also defined it very differently. The ones that is generally used is the ECAS-3. When there is symptomology is basically a decrease in NIH stroke scale of 4 or more. So if there is a decrease in NIH stroke scale, that is possible because the person had a stroke. They would actually have cerebral edema around the area, and they could have worsening of the symptoms. But if the worsening is more than the 4 or equivalent to 4, then you're actually looking at or potentially leading to death. Unfortunately, that is considered symptomatic, and that could be any hemorrhage. It doesn't matter if it is within the infarct core, not within the infarct core, it is remote or whatever. At the end of the day, if there's any hemorrhage that is causing an NIH stroke scale of more than 4 or equivalent to 4, and the neurological deterioration is attributed to it. Of course, the neurological deterioration is not attributed to person having pneumonia, having sepsis, and now obtunded, and NIH stroke scale is way above and beyond. The neurological deterioration is actually secondary to the bleed in the brain. In those cases, you are going to consider that to be a symptomatic intracerebral hemorrhage, and the cutoff time is up to 36 hours. If you look above, as a matter of fact, if you look at the NINDS trial, they actually went all the way up to 7 days. And the reason behind that was the first initial trial to look at if the patients actually have symptomatic bleed. At the end of the day, the most prevalent use is actually ECAS-3, but these are different trials that are available that have defined it differently. So the first and foremost, you have to understand how to define it radiologically, how to define its symptomatic intracerebral hemorrhage, and then, God forbid, if it does happen, what to do about it. What you have to do is, of course, stop this TPA, get a stat CBC, PTT, all the labs that you need to get, and then the mainstay of therapy is cryoprecipitate, and the lab that you have to focus on is fibrinogen level. You give about 10 units of cryoprecipitate, check the fibrinogen level, and then repeat dosing until the fibrinogen level is less than 150. You can give TXA in cases, or aminocarboic acid. To be honest with you, in those cases when you do not have access to cryoprecipitate, or patient's family is against giving blood, like Jehovah's Witnesses, in those cases you should give TXA. That is another mainstay of giving therapy in patients who cannot find cryoprecipitate or you are unable to give it. Get neurosurgical evaluation, get hematology evaluation, start all the supportive care, including ABCs. Make sure that the patient does not need intracranial monitoring, blood glucose, temperature, all that good stuff that needs to be done. Again, That was the symptomatic interstitial hemorrhage, one of the biggest things. The second other thing, which is quite rare to be honest with you, is angioedema. And that angioedema is sudden swelling of the tongue, and that you can block the airway, that you cannot actually oxygenate the person. In those cases, emergent endotracheal intubation needs to be done. Edema of the larynx can happen, and you have to be prepared. You have to be prepared for emergent cricothoraciectomy. You should give steroids and Benadryl, and then you should discontinue, of course, IVtPA. And if the patient is on any ACE inhibitors, you stop doing that right away and give epi as need be. Thank you so much for your time. Thanks for your time. Please like, subscribe, and share. Follow me on LinkedIn and Twitter.